Behind the Mask, the podcast. Behind the Mask. Behind the Mask. With Dr. William, PhD genius. Behind the Mask, Dr. William. The more you know, the better you do. Behind the Mask, the podcast.
So, welcome to another episode of Behind the Mask, the podcast, and today is a massive honor. This is the most highly regarded guest we've ever had on our podcast. I'm joined today by Dr. Jack Fisher. If I were to give him an introduction worthy of all of his accomplishments, it would take the entire length of the podcast, and he's a very humble person. And would probably be embarrassed by the introduction. But let me just say that he is a legend and a pioneer in plastic surgery, and he's been somebody that I've read and watched through my entire career because he's quite a bit older than me. I've really, from afar, and I've seen him speak multiple times at lectures, and so for me, this is really almost a dream having him here join us today. Dr. Fisher, I thank you so much for flying in and coming down and being on our humble little podcast today, and for allowing us to be able to once again, like thousands of people around the world, remove all of this wonderful information you have stored in that big, huge, beautiful brain of yours.
Well, thank you. I'm very excited to be here.
So I want to get started. I'll tell you just a little brief background of how this came to be. I read a paper 6 months ago or so, or maybe even a little bit longer, talking about surgical site infections. And I was sort of bold enough just to reach out to Dr. Fisher and say, hey, this is a great article. And it was in a little bit less of a known journal, very good journal, but not really always in our workspace in terms of plastic surgery. And so we talked about the article, and that was one of the reasons I said, I would love to have you come down and talk about that and share your wisdom, because while Dr. Fisher's retired now, just a couple of years, he has been working with Phase 1, which is a topical solution that I've been using for a few years now. And so I said this would be perfect. And so I just want to kind of set the stage a little bit, and then I want to not talk so much because we want to get your wisdom. But essentially, over the time, and when we were all medical students and residents, you learned to scrub your hands, and the nurses are watching you with eagle eyes and making sure that you're not contaminating things, and we're wearing gloves and boots and hats and gowns, and there's HEPA filters and multiple precautions have all been designed to keep bacteria away from patients while we're operating. Patients don't want infections. We don't want infections, but it's a complication that happens to some of our patients. And so this article was interesting to me in that they were able to go through and look at the bacteria that were causing these infections. They looked at spine surgery patients, and they did a gradient of infections that they found. So some infections in the cervical region, so the upper part of the neck, and then working down through the thoracic, and then at the very bottom in the lumbar area. And they did a very nice study where they looked at the bacteria in the patient's nose and mouth and anus, but then they could actually do a genotype, use genetic technology, right. And they could say, like, okay, well, this is Dr. Fisher's bacteria, and this is so-and-so's bacteria, and this is so. And so they could identify which bacteria belonged to the person, whether it came from their mouth or their nose or their anus. And then they could look in the infection, and lo and behold, they found, most of these infections were not coming from the hospital. They were not coming from the circulating nurse or the surgeon or some break in sterility or some problem, but they were coming from the patient's own bacteria. And it was very interesting. It was a very elegant design study where they said, oh, well, if you look at the infections in the neck, those are coming from up higher. And then as you work down the body, they get to the very bottom, those are the bacteria that are coming from the anus. And so they really demonstrated that very well. And then they started looking, well, we know where the bacteria are coming from, and why are they getting infections? Well, lo and behold, the people that were getting infection, more than half of them were resistant to the antibiotics that we were giving them. And because, just to sort of explain, when patients have surgery, they will come in and we start an IV, and then right before surgery, we administer the antibiotics, the anesthesia does, and then we make our incision, we start operating, and so we're feeling like, okay, we're good because we're giving them coverage for the bacteria that are there. And then the other thing that was really sort of terrifying was some of these patients were resistant to Hibiclens, which is our standard cleanser, chlorhexidine, that we used to wash the skin beforehand. So you can imagine there was a subset of patients that were getting surgical site infections from our surgery because the antibiotic we gave them didn't work and the soap that we used to clean them didn't work. So we were essentially operating on them without any antibiotics or any coverage at all. And so that sort of got me thinking, well, do we need to go back? Do we need to use alternate multiple ways to sterilize the skin? And that's what really sort of brought me back to Dr. Fisher and to his product, which I want to get into, this hypochlorous acid. And so I that's why I reached out. And so that's why Dr. Fisher's here, and he agreed to come here. And it took a small amount of arm twisting. I said, you're going to have a good time, and I hope we do. And so that's where I want to start. And talk to me then I would like to know and sort of what the history, your experience has been. When did you first start operating?
Yeah, well, you did a very good job of summarizing that article and really addressing the issue. We've always been living under the illusion that something is dropping off the ceiling or we haven't washed our hands properly, and that's what's causing infection. And it was a very unsophisticated approach to surgical site infection. And that article and several others that you just quoted really, really address the problem. We are the source of most of our infections.
Yes.
Years ago, I had abdominal surgery, and I got a MRSA wound infection. Where did it come from? It came from my nose.
Yeah.
It didn't come from, something in the environment. And so finally now we're getting more sophisticated and understanding where these infections are coming from. And the second thing you addressed, which is so important, is that we think we're protecting ourselves by using all these different antibiotics. And in reality, as you already addressed, in many situations, it's already resistant to it. And the other thing that we've done, and this has been going on for decades, is because of the abuse of antibiotics, whether it's oral or IV, we have developed resistance. And that's probably one of the biggest issues, is the development of resistance. Bacteria are very smart little creatures. They figure out, well, if you're putting this in my environment and you're trying to kill me, I'm going to change myself so that you can't kill me. And actually, the mutations to resistance happen very quickly. So one of the things, because infection, particularly wound or surgical site infection, has been a major interest throughout my 40-year career, and I've gone through all the different ways of trying to treat it, usually being frustrated. So one of the first concepts you need is, what can I use, or what can the doctor use, that never develops resistance? That's number one. If you can come up with something that will continuously work, then you've got something that has the potential of really helping. Well, we looked back at how does our immune system work? You made the comment about trying to sterilize an environment. We can never sterilize, as you know. All we can do is try to keep it clean. And the major thing that we have going for ourselves is a wonderful immune system. If it wasn't for our immune system, we wouldn't exist.
Right.
And matter of fact, historically, people will ask me, well, is this a new product? And I said, well, if you consider the beginning of the Pleistocene 250 million years ago, new, that's when the product that's when the product was created, because it's part of the normal mammalian immune system. Our white blood cells, as you well know, produce hypochlorous acid. And this has been known, well documented in over 1,000 publications since the 1940s. The problem is it's a very unstable molecule. When the body does it in the immune system, it lasts a nanosecond. But that's all it needs to do, because you have millions of white blood cells surrounding that problem, that infection, that area of contamination, and they only have to last each a nanosecond. So part of the agenda was trying to create a stable form of hypochlorous acid. So all we're doing is exemplifying or taking off from our normal immune functions using a product. And we can get into it, but there's lots and lots of hypochlorous acids out there. Every time you have a salad, your lettuce has been sprayed with hypochlorous acid, because that's been used in the vegetable industry forever to try to reduce the bacterial load.
And viruses, too.
And viruses and fungi.
And fungus, yeah.
Thank you for saying absolutely. It's all three.
Yeah.
Because, again, whoever designed our immune system was very clever.
Yeah, need to cover all bases.
Absolutely.
Yeah.
Let's kill everything except the patient.
Yeah.
And so it's a highly effective. But the ones that are used in industry, they have a generator, and it only lasts for a short period of time. So the other key thing is, if you were going to use it clinically, you had to create stability. And what's unique about this form of hypochlorous acid is, in an unopened bottle, it's good for up to 3 years. And that's the FDA approval, is up to 3 years. And then the other thing we can get into is there's so many other products, they're in plastic bottles. And what's been known, and there's, again, research going back years, you cannot put hypochlorous acid in a plastic bottle and have it be stable. It has to be in UV-resistant glass.
Yeah, the dark bottles.
Absolutely.
Dark glass.
Why is your beer in a dark glass? Why are a lot of the cosmetics and other products people buy in dark glass? It's simple. It has to block the ultraviolet rays because it oxidizes. You don't want your beer in clear glass because it'll ruin the taste of the beer. It's the same thing with hypochlorous acid. Has to be in UV-resistant glass. So that's the basis of the evolution of the product and why I started using it, because I was having so many problems with recurrent infection. A lot of my practice was redo surgery.
Right.
I would get all these complicated cases, previous infection. All the other products I tried were not very successful. And then 10 years ago, I started using this exact product, and all of a sudden my infection rate and other problems dropped off significantly.
And so, if we're looking at that patient, take me back when you first started operating. So when was that? 1980? No, 70s maybe.
I'm very old. So I finished my training in 80.
Yeah.
But I actually finished my training and went into practice in 1980.
Yeah.
And then I practiced until 2 years ago.
So what did you do at that time when you're going to the operating room and you're were you giving IV antibiotics?
Oh, yeah.
Yeah.
And we were abusing the antibiotics, and we were making things worse. We were living under the illusion that the more antibiotics, the better.
You were giving the triple antibiotic combo, probably.
And IV and 10 days. And all we were doing is creating resistance.
Yeah.
The bacteria were sitting there going, thank you, Dr. Fisher.
Yeah.
I really appreciate all these antibiotics.
I'm becoming stronger.
Because I'm becoming stronger, I'm mutating, and just keep giving us antibiotics.
And did you clean the skin with?
Usually like
betadine?
chlorhexidine, and then a little later, probably it was both a combination of that and betadine. Remember, both chlorhexidine and betadine were commercially developed in the mid-1950s. So they're not new products.
Right.
And prior to that, people were using what was called Dakin solution, which is just bleach.
Bleach, yeah.
And it's very cheap bleach, but the problem is bleach will kill everything, including the patient, because it's so damaging to tissues. But
Yeah.
there are people who still use bleach.
Yeah. And so, the concern that I have is we're particularly for things, liposuction, we don't really have problems with infection.
Right.
But, I'm terrified of putting an implant in a young patient and having that implant get infected and having to take it out. And that's miserable for patient and for surgeon and for everyone. And so when I was looking at that study and kind of having that feeling like, oh, gee, I can imagine if I've got a patient and they don't have any coverage, should I be using hypochlorous acid to be prepping my patient? And so I'll pose that question to you. Do you think I should?
So one of the benefits of hypochlorous acid is safe. I mean, this particular product was originally developed for ophthalmology. That's how safe it is. And we've tested it on mucosal surfaces. Totally safe. Again, it's part of our natural immune system. But what we found is, remember, every time you operate on a human being, there's bacteria there. All we're trying to do is get the bacterial load or number of bacteria down to a point where the human body can finish taking care of it. And that's what phase 1 is doing as an antimicrobial, is we're trying to manage that bacterial load. And we know that putting it in a surgical pocket like immediate breast surgery, primarily augmentation. And the patients are very lucky. The infection rate on primary, which means the first time you put in a breast implant, is extremely low, but it can happen. But more important than a overt infection, as you know, is the incidence of capsular contracture. That's the number one problem with breast implants, is
Yes.
getting a hard breast. Well, we have more and more data showing that capsular contracture is related to the bacteria in the pocket. And if you can do something to reduce that bacterial load and manage it, we know we can reduce capsular contracture.
And I want to get into capsular contracture. Let me back up just a little bit. So would you suggest, because after I read that article, I'm like, well, if there's resistance to chlorhexidine, and there's going to be resistance to the betadine that we use as well. I mean, we're without science here in knowing should we combine them. I mean, what would you do if you were in doing primary breast augmentation now with your knowledge of the resistance and your knowledge of the hypochlorous acid? Would you do a prep with chlorhexidine to begin with, wash that, and then do a prep with hypochlorous acid? Or would you would you do all three?
Yeah.
I mean, do you think that's overkill, or what would be your guidance in that way, knowing that we don't have those studies showing us?
Right.
But logically, based on your vast experience, what would you be your path?
Well, if I used all three, then I'd have a fourth component. I'd have a priest in the room praying over the patient because it makes absolutely no scientific sense. Matter of fact, what happens is one product neutralizes another. If I may correct you, rather than
please.
using the word resistance that these other products, let's use the word efficacy.
Okay.
Because resistance is a different phenomena, and you know this, where the bacteria actually are mutating and adjusting to a product.
Right.
So we're going to say one product is more or less efficacious than another product. And the problem with chlorhexidine and betadine, and we've done studies where we show, yeah, they work, but they take a lot longer to work. And if you're going to be in the operating room, you want something that works very quickly.
Mm-hmm.
And we've got several good studies, including some recent research out of Montana State, which is kind of one of the major centers for biofilm research. And we show that of all the products, hypochlorous acid, specifically, we use phase 1, was the fastest acting at penetrating that barrier around the bacteria and killing them. So it's efficacy. Part of that is rate related. And so, yeah, this is the ideal product for rinsing out that pocket before you put in the implant. Again, whether it's a total knee, hip, or breast implant.
But what about for prepping the skin, right? From
Oh,
the
okay.
get-go?
Good question. Actually, of all the preps on the skin, the one that lasts the longest is actually chlorhexidine. But remember, there's a big difference in those products, too. The chlorhexidine that you and I grew up washing our hands at the surgical sink is 4% concentration. The product that's out there now, Iricept, is 0.05%. And so there's a big difference. I would not use that weaker for the prep of the skin. I would use the 4%, and it sits around a long time. Here's the problem: allergic reactions. Mm-hmm. And there have been documented cases of significant allergic reactions. There are some people that you cannot put chlorhexidine gluconate on their skin.
Yeah,
The
I've
nice thing
certainly seen
about
that.
something like hypochlorous acid, phase 1, is, again, no allergic reactions. And so it's very safe, but it's very short-acting. So I would never say, well, you shouldn't put a long-acting agent on the skin, but you have to realize there is the risk of an allergic reaction. So you might use a combination. You know, one of the things that's always made me skeptical throughout my career when somebody would say you got to use this product is they would make one product great and one product terrible. And that's not reality.
Right.
You know, all these different products have a certain amount of efficacious ability. So to use a term and to explain it, it's called planktonic bacteria. And just think of plankton floating around in the sea. They're free floating. Everything kills planktonic bacteria. You can put Listerine, anything, in a pocket with these free-floating bacteria, and it'll kill it. That's not the issue. The problem with bacteria is they're really, really smart, and they establish themselves in these areas where they create a barrier. We call it biofilm.
Biofilm, yes.
And if you have this kind of surrounding material around it, these other agents are very poor at penetrating it. And it only takes a few hours to create it. When you wake up in the morning and you feel that kind of scummy layer in your mouth, that's biofilm. But there's good biofilm. You and I would not exist if we didn't have biofilm all over our skin. It's a protective layer. But then there's the pathogenic biofilm that causes problems with infections in breast surgery and other operations. And this is where hypochlorous acid, and specifically phase 1, truly is unique, again, based on hard science at its ability to rapidly penetrate.
So let's talk about the biofilm, and so for patients that may not understand, When we place an implant in the body during a breast augmentation or lift with implant, whatever the reason, that implant can become covered then in this biofilm.
Right.
And so it's a layer of bacteria. And what are some of the other things then that are in the biofilm that are composing that are going over top of the implant?
Yeah. So not to get too geeky
No, but
with
just,
an answer, but it's easy to explain. Think of an umbrella, and basically the organisms using and secreting what are called polysaccharides and other materials, and people are familiar with that term. They create this kind of gelatinous material around themselves because they don't want you to kill them. And they know that if they secrete this material and then they form a colony of bacteria, they're protected. Antibiotics have trouble penetrating it, everything. And again, it can only be a few hours with some organisms that form it. Now, again, we're lucky. We've got a wonderfully effective immune system. So when you put that implant in, there is going to be some bacteria there. But between the irrigation and your immune system, you're reducing the number of the bacteria. And if you reduce it enough, you're not going to form a biofilm. But you and I remember years ago, we would take out implants, and the patients had off and on infections, redness, and we would try to culture it, and it would come back negative, and it was very frustrating. And the reason is they had formed this slimy layer over the implant, the biofilm. And unless you use special techniques, which you mentioned in your first paper you talked about, and really analyze the bacteria, you were under the illusion there were no infections there.
Yeah, that was always the sterile infection.
Yeah.
Which was, I mean, how does that ever really make sense? But we couldn't detect it.
Right. So it proves again that smart people can be really dumb. And we were really dumb. Because I remember with the the microbiology report would come back and say, no bacteria.
Yeah, nothing.
And the breast was bright red. The patient had a temp of 103, and it was going no bacteria.
Yeah.
So actually, it was some of our colleagues at Mayo and other places, they used ultrasound to break up that slime, and they were actually showing there are plenty of bacteria there. But getting back to the primary point, we do a great job as far as our body in managing that biofilm. But if you go back in on a lot of implants with asymptomatic patients years later, and we all remember this, you'll take out the implant, you'll exchange it, and they come back 2 weeks later with redness and signs of infection. What did you do? You stirred up that biofilm that had been sitting there for a decade.
Yeah.
And we didn't understand that concept. Unfortunately, we do now. We have a lot more sophistication. And the key is, and again, with some really good science at a couple different institutions, we've shown that phase 1 is the fastest we know of any product as far as penetrating. And again, that's hypochlorous acid. And I can't take credit for it because I'm going back to the beginning of the Pleistocene 250 million years ago. And actually, they have found some frogs even before that were using hypochlorous acid in their immune system.
Well, it's so just to, and this is, I think, you've touched on it earlier, talking about sterility and how you can never really get a human patient sterile. And so we do what we can with the antibiotics. We do what we can with the prep. We put the implant in, and then I used phase 1 because, from reading your material, to be able to irrigate. But there is bacteria that are on as soon as we open the implant, which has come sterile from the factory, and we take it. We don't touch it. We put it in the funnel, and we don't want to touch it to the skin, and we cordon off the skin so that it doesn't touch the implant and everything. But there is bacteria that are on there. It's impossible not to. And so then we're relying on, the immune system has to clean up some of that bacteria, because I think it's important at this point to kind of illustrate that you can have bacteria and not have an infection, because it's really what an infection is it's where the bacteria have grown in quantity enough that they start to really just outnumber the defensive system of the human body.
Exactly.
And you get this large group of bacteria, and that's really what an infection is. So we're relying on the immune system to clean that up, and then we're relying on, at least I do, on the hypochlorous acid to do that. And so it makes sense then, if we're able to do that, okay, well, we shouldn't really develop a biofilm. And we know that, at least that's our current thinking, is that the biofilm with the bacteria in it is what's leading to the capsular contracture. Now, capsular contracture is where your body has the implant go in, your body forms a capsule around it. Every single foreign body that goes in the body gets a capsule around it.
Right.
But in patients with breast implants, that capsule can become thick and firm and contract, and we think that's related to this biofilm and the bacteria that are there, which is the whole reason why we're trying to decrease that biofilm from the very beginning. And so it's a natural sort of step then to say, okay, well, if we're now able to really decrease the biofilm, we should be able to decrease the problem with capsular contracture. What was the percentage you would quote patients for capsular contracture, by the way?
So early on in my career, it was pretty high.
Yeah.
I would tell them probably within the next few years, you have at least a 10% chance.
That's what I started.
Yeah,
that's what I would say.
coming back at some point. Because one of the problems, we tell them it'll happen within the first year. That's not true. It can happen 2, 3, years later. And then as implants got better, and I think our technique got better, I would tell people maybe 2, 3, 4, 5%, something like that.
Mm-hmm.
And that's what I did. The problem, and this is where I know you're going, is once they have that capsule, what do you do about it? Because those are the patients. When I would operate on patients who already had a hard capsule, and we graded 1 through 4. 4 is like a hard rock.
Right.
3 is pretty stiff. 1 is normal. These patients would come back with a capsule level 3, 4. I would tell them, I'm going to do everything I know to do to reduce it if we reoperate. And I tell them probably over the next few years, you have a 30 to 40% chance of it coming back. It was the most frustrating surgery I did because I just didn't feel I had a good solution. And then with our knowledge of bacteria, biofilm, et cetera, several of my colleagues did a really, what I consider groundbreaking study 5 years ago, where they took 133 Baker 3-4 capsules.
133 patients with...
No, 133 breasts.
Breasts.
It was like 65 patients because some were bilateral, some were unilateral. And they removed the capsule. They irrigated with phase 1. And some used antibiotics, some didn't. And they followed them for up to 2 years. And the recurrence rate was less than 1%.
Yeah.
And it was incredible.
That's unbelievable.
Yeah. And just a month or two ago at your hometown of Vancouver, they presented 5-year follow-up. And it was still less than 2%. That's unheard of. And I have other colleagues that have been doing it who haven't reported their data, but they report the same exact response. And I know of no other data that can show that low incidence or low of an incidence of recurrence with any other technique I've ever used. And I've tried everything. I mean, the only thing I haven't tried is chicken soup. I mean, and my grandmother would be proud of me, okay? But nothing worked, and it was so frustrating. The other thing is there are studies in the literature where they only do like 1-year follow-up. That's worthless because although the majority of capsules do occur within that 12-month period, they just keep occurring and occurring. And to have 5-year data now, and it was so exciting to hear this presented in Vancouver by my colleagues, And again, we and the company had nothing to do with that study. That was totally independent. That's remarkable data.
Yeah, and that's even, just in speaking with you and listening to you, that's why I moved to. I don't prep all my skin with phase 1, but I'm going to. But I certainly irrigate all of my pockets, either if it's a primary breast augmentation or if it's a capsulectomy. I'm removing the capsule and doing that. And this data from Vancouver showing that capsular contracture rate is unbelievable.
Yeah, I know. I think people are skeptical about it, but these are 3 of the most prominent plastic surgeons in our specialty.
Yes.
They don't make up numbers.
No.
And what makes the data even more valid, as you know, the attendings don't write the paper. It's the poor residents.
Yeah.
And all the poor residents do is go through the charts and collate the data.
Yeah.
And they have no bias.
They've got no skin in the game.
They just want their name on a paper.
Yeah, they're collecting data and hoping to get published.
And then the attendings take credit
all the
for it.
credit, yeah. But to be able to have that now, if you talk about, I know we've talked about resistance and efficacy, but when you're not going to become immune. The bacteria are not going to become immune develop any resistance to this.
Right.
Why?
Well, again,
why do you develop resistance to an antibiotic? So I'm a bacteria. Well, let me back up and just say, because I think this point always seems to get lost on patients. I used to really like when patients would say, I would never take Botox. I don't want any toxins in my body. Right. I mean, it is kind of funny to market a product and you call it like toxin, but they'd say, I never want that. And then I would say, like, well, have you ever taken an antibiotic? And I'd say, well, of course. I'm like, well, you've taken toxins.
Right.
Because if you have bacteria A and you have bacteria B, well, they're both trying to get a little piece of the pie, and they're competing against A and B, and they're trying to survive. Well, A will make something to kill B, and B makes something to kill A. Well, if we get infected with bacteria B, we take whatever A produces to kill B, and we take that ourselves to kill B. So we're taking, toxins. So, and those bacteria can develop that resistance to that toxin, to that antibiotic. But there's other ways of killing a bacteria where you can't develop any resistance, because it's like taking a hammer to the bacteria, and no one is ever going to be resistant to having a hammer come down on them.
Yeah.
So can you, in that sort of scenario, talk about how this works in terms of not developing the resistance?
So what you described with the bacteria is simple Darwinian selection, that when you use an antibiotic, you're selecting out, and the strong survive or the strong mutate based upon how antibiotics work. So it's a fairly straightforward phenomena. The other problem we've always had is, you and I remember post-op, we'd always give people 10 days of antibiotics. Yeah. Worst thing we can do. Most surgeons today, it's 1 day or just an OR dose, realizing that they don't want to get into that natural selection. Okay, so how does hypochlorous works? It's by oxidation. And there are lots of ways that you can oxidize things. I mean, you put something out in the sunlight for a long period of time, you're looking at the problems with oxidation. And so because it's not a specific selective phenomena, but it works uniformly across the board, you're not leaving any of the bacteria really around to say, I'm going to go find a way of making a biofilm and get out of here for a week so I can come back and cause a problem. And so it has to do with a very uniform way of damaging or killing that bacterial cell wall. The other thing is, there are certain antibiotics that work on one group of bacteria, as you know, but not on others. The unique thing about hypochlorous acid is basically it works on all bacteria, fungi, and most viruses. I mean, we tested it on COVID, several years ago, and there were other people who did it too, and they showed that hypochlorous acid will kill COVID. It's a uniformity and not leaving anything around that can mutate and develop a resistance to it. So the key word is the bacteria or the product does not allow resistance to occur, but it's the mechanism, that oxidation.
Would it be fair to say that this is kind of like punching a hole in the wall of whether it's a virus or fungus or bacteria and just physically breaking up that bacteria?
Yeah, it is a physical event because you're
simple way.
destroying,
Yeah.
you're bursting that cell
Right.
wall. Absolutely.
And so you're never going to get a resistance to having something come in and punch a hole in the wall of a cell and then have that contents come out. And so let's talk about, this is related, talk about the breast infections. Let's say you do have a infection of an implant, and we typically see that at what point?
If it's a primary case.
Yeah, just a very
well,
someone comes in
there's
for a
two
breast-
groups. If it's related to surgery, it's usually within a few weeks or a couple months.
Yes.
But throughout my 40-year career, the only two cases that I know of, and remember, patients don't always go back if they have a problem to their
Right.
original doctor, but the two that I was well aware of is one of my patients developed a severe kidney infection, and this has been well described, either a bladder or a kidney infection, and what it does, it seeds the blood vessels or the vascular system, and then what the bacteria do is they kind of hone in on where there's something like an implant or a recent surgical procedure. That's why at one time people were talking about patients with implants who are undergoing major dental procedures, and some people do recommend it still today to use prophylaxis. And I had another patient with a bad injury got an infection and seeded her implant. So that's a delayed phenomena just by virtue that you've got an implant sitting there, and bacteria love implants. The other is something that occurs related to the surgery itself, and that's usually within a few weeks, sometimes a few months, you'll see. We just completed a study with total knees, 1,000 total knees using phase 1. There was only one infection, and it was in a diabetic with a BMI of 56. And for people who don't understand BMI of 56, that's a very obese patient. And we know obesity increases your risk of infection. So out of that 1,000 total knees, the infection rate was 0.01 in a very high-risk patient. And so we got great results. And what we did is we made sure, to answer your original question, we followed for at least 3 months minimum. So what we know, if you're going to see an acute infection, you're going to see it within probably that 3-month period. And that's what they kind of used as their hallmark, although the patients are followed for longer. And there are some institutions with total knees that have much higher infection rates. The infection rate in general with total knees, total hips is very low, but still out of 1,000 patients. But then there's a whole nother issue we haven't addressed that's unique to hypochlorous acid, and that is it promotes healing. And that's a very unique characteristic that no other product out there. And again, I didn't design hypochlorous acid. Somebody else created it, okay? So I can't take credit for it. But that was my religious experience. But it promotes wound healing, and that's unique to hypochlorous acid. And it has to do with promoting certain cells that we call epithelial cells and keratinocytes that allows the wound to heal. And one of our orthopedic surgeons, who's been using phase 1 now for 5 years on all his total knees, has told me that his incisions at 6 weeks look like they're 3 to 4 months old. And I've told him that doesn't surprise me because we know that's another benefit of this product. Again, no other irrigant can say that it promotes and helps with the healing process. And some of them will significantly delay it. And we've actually studied other products out there and showed that they're cytotoxic.
Yeah.
And what cytotoxic means is that it kills cells. And again, no cytotoxicity here.
And so that the wound healing, for those products that are inhibiting the wound healing, that sort of, as we learned in medical school, and we deal with this all the time with patients always wanting to put alcohol in their incisions and things like that, where sure, the alcohol is going to kill the bacteria, but you're killing everything else
Right.
in the area that is going to heal. So you're not only killing the bacteria, but you're now also killing everything else that's trying to help the problem.
Yeah.
That's trying to kill the bacteria and try to heal the wound. So that's hurting you. Well, when I use phase 1, I put it in the pocket, and I irrigate the pocket, and then I also use it all around the surrounding skin. I haven't noticed the healing, probably because I haven't been paying close enough attention to that. But in terms of applying it, you think that's wise then, based on what you just told me, what I'm unintentionally doing, just because it seemed like a good thing to do, just it's where the incision is, that's getting covered with hypochlorous acid as
Yeah.
well. And you think that we're improving wound healing by I'm doing that in my incisions.
Probably, but actually where you're doing the most improvement of the wound healing is the irrigation, because a lot of the healing is going on below that epidermal layer. We've got this thin layer that's basically wax paper on our outer layer of skin. That's why we can go swimming and take a shower. Otherwise, we'd all be looking like prunes all the time. So that epidermal layer is kind of waterproof. But then you get down to those deeper layers of skin. So it's actually that initial irrigation. But some's going to seep in there. And there are other people doing work with hypochlorous acid, putting it into gel forms exactly for that reason. And we're talking to another company that actually makes a hypochlorous gel. So, where I've seen the big difference is an open wound. On the bottom of a breast, sometimes you'll get just a little
triple
opening
point.
at
Yeah.
that T point or others. And everybody who uses it on that all say how quickly it heals. And the reason is when you get a burn, what did Grandma do? She told you to put butter on it.
Right.
Well, that actually wasn't that crazy, and the reason is you have to keep it lubricated and moist. If you let it dry out and form a scab, that scab becomes a barrier to the migration of the healing cells, called epithelial cells. And if you keep it moist and lubricated with Grandma's butter or whatever, those epithelial cells are more likely to migrate. And we know that hypochlorous acid promotes the process called epithelialization, which is just those little cells creeping across that surface to close the wound. And that's a major, major benefit. And I've treated burns, other skin graft areas with it, and absolutely have seen significant increase in the rate of healing. But that even dates our development of this product. People have known that for a long time with other basic research that HOCl has that process. So this big bottle that you have here, the 235 ml bottle, once you open it, if you don't use all of it, and in surgery you use the whole bottle, but let's say you don't and you put the cap back on, it'll stay good for 2 months. The small bottles, which we use a lot for spraying on wounds and drain sites, once you open it, are good for a month. Why? Well, first of all, people will say, well, the top of this bottle is plastic. You keep saying you can't use plastic. Actually, the inside of this bottle is Teflon. There are 2 things we know you can put hypochlorous acid in and stay stable: glass and Teflon. Teflon bottles are very expensive, much more so than glass. But what happens once you open the bottle? The level of the solution drops. And what happens is the chloride, which is what's killing everything, the chloride ions are popping out through the surface and the concentration drops. And that's why we tell people if you don't use it all, you can use it for up to 2 months and it still has a good concentration. And there's good science and phenomena of why in any solution some of the product comes out of that solution, but it still makes it a uniquely stable product.
Now, the orthopedic, you brought up orthopedics, and we get so wrapped up in our own world of plastic surgery,
Right.
but obviously when we're talking about surgical site infections, we're talking about everything, every single type of surgery that's happening all throughout the country every day. The orthopedic surgeons, they must love this. Is it, or they haven't adopted it? I mean,
Yeah,
it doesn't
so
make sense to
we've
me.
had some penetration, but we have so many other competitive products. It's a hard market to get into, and hopefully that's our agenda, because the number of total knees and total hips in the United States far exceeds anything we do in numbers as far as plastic surgeons.
Yeah.
I mean, I think there are about 300,000 primary augs
Right.
in the U.S. There are over 1 million total knees. And then you have total hips. So the numbers are incredible. And an interesting statistic, if you get an infection in your total joint, and then at a later date, the other knee or the other hip needs to be done, you have a 3-fold chance of that other joint getting infected.
Wow.
And that's dramatic. And the question is, how do you explain it? Even if the first joint seems to have resolved and is okay, for some reason, those other sites now are at much greater risk for infection. So that in particular is important. The other thing we have found is we have some orthopedic surgeons who have specifically used phase 1 after an infection with a total knee. And it's one thing to have to remove a breast implant for a couple months. It's a whole nother issue if you have to take a total knee out. Yeah. And sometimes you can never replace that total knee, and they put in what's called a spacer or a rod, and it just becomes a fixed leg.
Yeah, it's miserable.
And so that is really a critical area.
Now, you have made me over the years. I'm very enthusiastic about the phase 1, and it just dawned on me, and maybe I'm really starting to become too much of a zealot. But if you're talking about wound healing, and we know that the wounds are not totally sealed for 24 or 48 hours after surgery. We put our stitches in and we say the wound is closed.
Right.
But we know that it's not completely closed. We've reapproximated things so that it appears closed. It's not bleeding. There's no fluid coming out. But ultimately, we're still relying on the body's epithelial cells to walk across that final little step to close things.
Right.
And we're talking about benefits of healing. I mean, would you think I was completely nutty if I sprayed every single one of my if I sprayed my tummy tuck for the first 2 days post-operatively with phase 1? Would we think that I completely lost my mind, or would you think, gee, this guy's really onto something here?
Well, there's two things here. One, you're totally sane, and actually you're not that smart, because I've been doing that for years.
Have you really?
Yes.
You really have?
Yeah. So drain sites. Every one of my patients when I was
I'm
practicing.
a genius because
You're a genius.
Because
yeah.
you're a genius.
Yeah.
And
We're both geniuses.
And I'm thinking of doing what you've been doing.
Yeah. So every patient,
I'm a little late to the game.
just by a few years, every patient was handed a 40 ml spray bottle. The biggest problem, as you know, is drain sites. Mm-hmm. And those are totally mismanaged. Mm-hmm. What do? We were taught to put antibiotic ointment and have the patient put it around the drain site where it enters the skin.
Yeah. I mean, I stopped doing that, but I did
And you
originally.
did the right thing,
Yeah.
because all it does is trap the bacteria in the skin, and the bacteria go, thank you so much for being dumb.
I never saw more problems with drains
Then when you use
when
yes,
I used that
but
stuff.
that's what's still taught, and
Yeah.
all it does is it keeps the bacteria in. So anytime a patient with drains went home, I want you twice a day, go squish, squish with the phase 1. I never saw redness, because you know it's that early redness that tells you
Yes.
you're getting an infection.
Yeah.
Absolutely. And then, like a tummy tuck or a breast, I would say for the first 24 hours, because you're right, after that, the skin's sealed,
Yeah.
it's not going anywhere. Spray a little on where the incision would be. Do I have hard scientific controlled data? No, but I have my clinical impression. But as far as drain sites, there's no question. I used to pull out drains prematurely, even though they were still draining, because I was afraid of a secondary infection, because if a drain sits there too long, we know bacteria can go back in and track along the drain.
Yeah.
And so I'd pull out a drain, and then 2 days later, they got a big seroma. Once I started using phase 1 on the drain site, I could leave it as long as I needed to. That was one of the early things that actually changed my practice, was using it on drain sites. And I learned that because I had been treating chronic wounds and burns with phase 1.
Wow. Okay.
So you have documented how smart the two of us are. I doubt our wives would agree with either of those facts.
Well, this is just a fascinating topic. Let me see if I can summarize some of the points that we have made. And I mean, I think probably the most interesting thing from our point of view is the data that you were talking about with the capsular contracture.
Right.
So I know, and I've adopted this in my practice, and I think that it would become just universal in the plastic surgery community with irrigation of not just implant exchanges when you're doing capsulectomy, but just irrigation of all the primary breast pockets. Decrease the bacteria that's there, decrease the biofilm, and decrease your possibility of developing capsular contracture. And you have good data to support that. And that's one of the things that I think probably for patients and understanding is, we do things based on data. And you've been a master through your whole career of being a true scientist and collecting data. And you have to have that sort of Louis Pasteur sort of concept of, chance favors the prepared mind. You have to have some sort of thinking that, what's going on and how might this benefit. But you haven't used just intuition or things like this. You've done the studies, you've done the data. And so you've got solid data. I think that's just an absolutely no-brainer to use the phase 1. But I've only been focused on that for breast because of the capsular contracture and getting an implant infection.
Right.
But I think after today, with your explanation, I know we've talked in the past about the wound healing, but I think with your explanation today, with the wound healing and your experience, with your clinical experience with the drain sites, I think I'm going to start using this for really tummy tucks. I'm going to wash out my tummy tuck before I close, and post-operatively treat patients. So you have them treat themselves with the
spray.
Just give them a little spray bottle.
Yeah,
and say,
because they would have a subcuticular and spaced out stereo strips.
Yeah.
And I've never been a big believer in lots of dressings. A little to pad, and you've got some of your own fancy dressings that make a whole lot of sense. And stuff.
That's why I do, and that's that OG Easy Bra,
Right.
which is it's a bra, but it really is a sterile dressing, and it's absorbent, it's comfortable, it's soft. I like how it keeps the implants in the correct position. but I'm exactly the same. I don't need to put a whole bunch of dressings on anymore, and it's unnecessary. But would you? I don't put my steri-strips vertically. I put everything horizontally. Would you? I mean, I wouldn't see any problem, but I wanted to know what you thought of just spraying right over the
Steri-strip?
the steri-strip.
I
and
don't know
letting-
how much would penetrate
Well, I
through
wonder
it.
if over sort of the edges, if anything,
Yeah,
through.
and Steri-strips, they're pretty resistant to water. One of the things we hadn't brought up that you just reminded me, unlike other products, it's recommended that you irrigate them out at the end of the procedure. The nice thing about phase 1 is you can remove it, but you don't have to.
No, I never do.
Yeah, and the reason is the body just converts it to water and saline.
Yeah.
I mean, with a short time, it's gone. Now, that's a little, maybe not a downside, but that's why you can't compete with some of the long-acting products. The benefit of hypochlorous acid, it acts so rapidly in general, but it also is gone within a short period of time, which actually is a benefit because you don't have to worry about the product. But I wouldn't promote it as a long-acting product. It's short-acting, but that's why in many situations, like with drain sites, I would have them spray it twice a day just over the drain site where the skin exits. The other thing that I hadn't mentioned, hypochlorous acid is also a natural anti-inflammatory. And if you ever get a chigger, do you have chiggers in Florida?
The little
I don't know what they are, but they're horrible
Yeah.
when you get the bites.
yeah, around the ankles. And,
Yeah, they're dreadful creatures.
Yeah.
This is the best thing in the world because
that right?
Yeah, I spend a lot of time in the yard and I get mosquito bites and stuff.
Yeah.
I've got my spray bottle, and the reason is being a natural anti-inflammatory, it takes away the itching, which is a wonderful thing. And the same thing around a drain site as it's healing.
Yeah.
Patients will get itching.
Yeah, they
They'll
complain
tell
about
you,
that,
they'll tell you after I sprayed it, why is it itching less? Again, another component of hypochlorous acid in general, it's a natural anti-inflammatory. So there are a lot of things that this particular substance, again, created by our immune system, provides. The other thing is, what could be better than to use something that our body has already created? Where all these other products are sort of man-made, developed in the chemistry lab, this was developed by our white blood cells and our natural immune system. So if you want to think about natural, that makes it a very unique product.
Yeah, I mean, I would never wash out a tummy tuck with chlorhexidine.
Right.
And I mean, that would be that just would never would just never cross my mind because it's toxic. And I've certainly seen what you talked about before with the autoimmune response and I mean, I've had patients sometimes you wash them and then
they go bright red
they're
and
all
get
red.
yeah.
And it's up to their neck. And
There have been a few cases of anaphylaxis, but that's usually with the stronger concentrations. But if you read the bottle on even the 0.05%, one of the warnings is allergic reaction. And that's the one nice thing about hypochlorous acid. There's never been a case of an allergic reaction.
It would be like us being allergic to oxygen. I mean, it's
We would
impossible.
not be sitting in your beautiful studio with your wonderful staff sitting over there listening to us. Are they still awake?
Yeah, they may have
They're
dozed
still
off.
awake. They wouldn't. None of us would be here if that existed. I mean, that's the joke. If we didn't have all these benign benefits, we wouldn't be around. The only thing would be some frogs.
Well, Dr. Fisher, I can't thank you enough for going through and explaining the history of Phase 1, and I'm certainly a huge proponent, and I thank you very much for coming on
I've enjoyed
our
this.
podcast, and it's been just a pleasure.
This
So,
has been fun.
Thank you very much. Thank you very much for watching. Remember to subscribe and like, and tune in again for another episode of Behind the Mask, the podcast, and we look forward to seeing you again. Thank you.
That
Thank
was-
you so much.
You're about to experience Behind the Mask, the podcast. We are the mask. Behind the podcast.